topic of skin. Now these are the competencies which I am going to cover in this lecture is that is describe different types of skins and dermatomes in the body, then explain principles of skin incisions and their surgical importance. Now this skin, it forms the external covering of the body. It is the largest organ, forming around 15 to 20% of total body mass. Then it is continuous with the mucous membrane at the orifices of the body. It varies in thickness at different parts. So at eyelid, it is less than 0.5 millimeter in thickness, and on the middle of the upper back it is more than 5 millimeter. Now what are the functions of the skin? Now it acts as a barrier against loss of body fluid. It gives different kind of protections that may be that is mechanical, chemical, osmotic, thermal and photo damage, so that can be protected. Then is vitamin D synthesis from 7-dihydroxycholesterol under the influence of UV rays. Then it helps in the absorption of certain skin ointments. So it helps in the temperature and pH regulation of the body. Then excretion through the sweat gland, it helps in the excretions of the different salts from the body. So then endocrine function is synthesis of cytokines and growth factor. Sensory function is because different nerve endings they are present, it contains receptor for touch, temperature and pain. So these are the functions of the skin. Coming to the structure of skin. Skin is made up of three layers, that is epidermis, dermis and hypodermis. Then is coming to the epidermis. Now this epidermis is ectodermal in origin. It is made up of stratified squamous epithelium. This epidermis is avascular, so nerve supply is by the free nerve endings. Now what are the different layers of epidermis? You can see starting from the basal portion, it is stratum basale, then comes the stratum spinosum, then comes the stratum granulosum, then comes the stratum lucidum and stratum corneum. So if we start from the upper part to the lower portion with this mnemonic, we can you can remember the different layers of the epidermis. Come, let's go get sunburned. So C for stratum corneum, that is the topmost layer, then stratum lucidum, then G for stratum granulosum, S for stratum spinosum, then stratum basale. So these are the different layers of the epidermis. Now these layers, we divide them into two zones, that is cornified zone and germinative zone. So under cornified zone, stratum corneum and lucidum they come, and in germinative zone the stratum granulosum, spinosum and basale, so they are present. Then the cells undergo mitosis to form the mature cells. Turnover time for this is 15 to 45 days. Now what are the different cells which are present in the epidermis? The cells of the epidermis are given the name keratinocytes. So then next set of cells they are present are melanocytes, then Merkel cells and Langerhans cells. Coming to these melanocytes, so these are basically arising from the neural crest. Then they synthesize the melanin pigment which can be transferred to other cells of the epidermis by way of dendritic processes. The Langerhans cells, these are the star-shaped bone marrow derived cells migrated to the skin via blood. So they are active in immune response, present in the stratum spinosum of the skin. You can see, so these are the cells. Then coming to the Merkel cells, these are the neural crest in origin found in basal layer of the thick skin, and these cells have sensory function. Now these are the different appendages which are arising from the skin, hair, glands and nails. Glands include sweat and sebaceous glands. Coming to the next layer of the skin, that is dermis, it is made up of connective tissue. It has two layers, papillary layer and reticular layer. The papillary layer lies just below the epidermis, you can see. So this is the epidermis. So this is the papillary layer which is just present beneath the epidermis. It includes the dense connective tissue of dermal papilla. The papillary layer in the dermis is what forms our fingerprints basically. So this is because of this layer, the fingerprints they are formed. Best developed in palms and soles. So this papillary layer is best seen in palms and soles. Coming to the reticular layer, this is the deep layer. This is the deep layer, mainly made up of thick bundle of collagen fibers. You can see in this collagen and elastic fibers are also visible. Then adipose tissue is also seen. The arrangement of bundles in the direction of mechanical force give rise to the cleavage lines of Langer. Coming to the next layer of the skin, that is hypodermis. So this is the loose connective tissue which helps in sliding the skin over the deep structures. So this is the hypodermis. Layer of fat according to the nutritional status of the person, also called as superficial fascia or panniculus adiposus. Now coming to the various types of skin. So first is a thin or hairy skin. Thin epidermis made up of keratinized stratified squamous epithelium. So this in thin hairy skin, the epidermis is thin and stored in the, if the we see the different layers of the epidermis, stratum corneum is very thin in that. Then hair follicles, sebaceous gland and sweat glands are present in thin skin. It is found in all other parts of the body except palms and soles. Coming to the thick and glabrous skin, so presence of thick epidermis. So this is the basic difference between thick and thin skin. So it is made up of keratinized stratified squamous epithelium, but in this case the stratum corneum is very thick. But hair follicles and sebaceous gland, they are absent in this. Sweat glands are present. It is found in palms of the hands and soles of the feet. Then presence of distinct layer of stratum lucidum is present in thick skin. What is the applied importance of the skin? Why we are discussing the skin? So there is one disease, that is albinism. So it is autosomal recessive disorder associated with the congenital agenesis of the enzyme, that is tyrosinase. So what happens in this? That is total depigmentation of the skin is seen. Second applied aspect of the skin is vitiligo. It is the localized depigmentation. So melanocytes lose their ability to produce the melanin. Coming to the next, that is moles. That is melanocytes are clustered in high densities. So this is the mole. Dermatitis is what? It is an inflammation of the papillary layer which is present just beneath the epidermis. So it is caused by infection. It may be because of radiations, mechanical irritation or chemical irritation, then characterized by itching or pain. Then coming to the blisters, if the skin is rubbed too hard, the stratum basale tears away from the basement membrane and causes a gap which fills with fluid, and that structure which is developed after that is, we call it as blisters. The epidermis then dies because it is too far away from the nutrients, because the fluid is just present in between. That is why the top of the blister dries up. If the blisters are small, less than 5 mm in diameter, they are known as vesicles. And if they are larger, greater than 5 mm in diameter, they are termed as bullae. So this is the bulla and these are the vesicles. Coming to psoriasis, decrease in cell turnover time, which was 15 to 45 days in normal span. So if that is decreased and the increased proliferation of the basal layer cells, it happens, results in the greater epidermal thickening and rapid renewal of the epidermis. Coming to the skin cancer or carcinoma, so two types of cancers they are seen, that is basal cell carcinoma and squamous cell carcinoma. Now the basal cell carcinoma is most common type of skin cancer. It is slowly growing and locally invasive, almost never metastasizes, found in sun exposed areas of the skin. Then squamous cell carcinoma, it is the second most common type of skin cancer, arise from the epidermal keratinocytes, more likely to metastasize. So more invasive than basal cell carcinoma. Coming to the next topic, that is dermatomes. So dermatomes, basically the skin is supplied by a single spinal segment. So this is a TS of the spinal cord showing the dorsal root and ventral root and the spinal nerve. Now cell bodies of the sensory neuron are located in the dorsal root ganglion. In this here they are present in relation to the afferent or sensory nerves. Spinal nerve root supplies a structure assigned to them according to their association with the spinal segment. So there is overlap of spinal segments supplying the adjacent dermatomes. These overlapping dermatomes are called as signature zones for identifying the spinal cord segments. This overlapping is observed in T2 to L1. So here the overlapping is happening. Dermatomes are represented by narrow band of skin running horizontally in the trunk. Due to growth and rotation of the limb, but during development, the dermatomes are arranged longitudinally along the axis of the limb. So in the limb, they are arranged along the longitudinal axis, but in the trunk, they are horizontally arranged. So there are 31 pairs of spinal nerves, but the dermatomes are only 30. Reason is that dorsal ramus of C1 spinal nerve has no sensory root. So that's why the dermatomes are 30. Now, if we see the dermatomes on the face and scalp, the sensory innervation of face and scalp is by trigeminal nerve. Hence, the first dermatome to begin with is C2, which overlaps the trigeminal nerve on the front and the of head and neck. You can see this area is supplied by the trigeminal nerve. So here is the C2. So C1 does not have any sensory roots, but C2 it is starting from this. So C2 is visible. Now the dorsal rami of C5 to T1 are not involved in the supply of trunk due to development of the upper limb at these spinal segments. So hence these segments are involved in the cutaneous innervation of the upper limb. Because of this, the C4 dermatome is continuous with the T2 dermatome. Whereas C5 to T1 they are reaching to the upper limb. They are supplying the upper limb. Now the dermatomal distribution of the upper limb is C4 to C6. You can see here C4 to C6 they are along the lateral aspect of the limb. C8 to T1 they are along the medial aspect of the limb, and C7 in the middle. For lower limbs, due to medial rotation of the developing lower limb along its long axis, the dermatomal distribution is oblique in orientation. L1 and L2, you can see here, L1 and L2 dermatomes are placed adjacent to the S2 and S3 as the intervening segment, that is from L2 to S1, moved into the most distal part of the limb. You can see here. So they are reaching here. So that's why the L1 and L2 they are lying adjacent to the S2 and S3. The dermatomes of the lower limb are arranged in a downward sequence on the front and in an upward sequence on the back. You can see here. So in the downward sequence they are running here, but on the back it is on the upward sequence. Now clinical application of the dermatome is knowledge of the dermatome is important in neurological examination to identify the involvement of the spinal segment or localization of injured spinal segment. Sectioning of the single dorsal nerve root results in the hypoesthesia. What is that? That is diminished sensation. Damage of at least 3 adjacent dorsal roots results in dermatomal anesthesia. I told you the overlapping of the dermatome. So that just if the only one segment is involved, then it is diminished sensation. But if it is involving 2-3 dorsal nerve roots, then it is definitely total loss sensation. Total loss of sensation it happens. Sharp radiating pain along the distribution of dermatomes suggests herniated intervertebral disc putting pressure on the segmental nerve. The next applied for the dermatome is pain or rash along the distribution of the dermatome indicate disease of the related nerve root. So most common cause is viral infection. If infection is by the varicella zoster, that causes the chickenpox, but if it is by herpes zoster, that causes the shingles. Coming to the next important topic, that is skin incision and their surgical importance. What are the basic principles of incision? The success of any open surgical procedure requires a well-chosen incision based upon sound anatomical principles and closure with a technique that will result in secure, well-healed wound. So a well-planned incision has the following essential element: accessibility, that is size of the skin incision must guarantee a good visibility of all anatomical structures which are to be prepared. Then extensibility, a surgical incision must be as short as possible, as long as necessary, ability to extend the wound. So that should be extendable. Then security means the precise planning of the incision requires in the first place of knowledge of longer skin lines for preservation of function and secure closure. So these are the 3 basic principles, that is incision, a well planned incision should be, the accessibility should be there, extensibility should be there, and security should be there. A surgeon is responsible for choosing the best incision for a planned procedure, so including therapeutic aims, practicability, functional, aesthetic results of scar formation. Now, the choice of the incision depends upon the types of surgery, whether it is elective or emergency. What is the target organ? That decides the type of incision. Then, surgeon's own experience and preferences. Then, previous surgery. Skin incisions are used for approaching the body cavities. So, each incision has got both advantages and disadvantages. The surgeon is the right person to choose the appropriate incision for the viscera or the region in which he has to operate. So these are the 9 regions of the abdomen, you know it. That is right and left hypochondric region, right and left lumbar region, right and left iliac region, and in the center, starting from the upper part, this is epigastric region, umbilical region, and hypogastric region. Now, for surgical point of view, if we divide the abdomen into 4 quadrants, right upper and left upper, right lower and left lower, and then this is the McBurney's point. So this is the anterior superior iliac spine, this is the umbilicus. So here the McBurney's point is present. Now Langer's lines are basically corresponding to the natural orientation of the collagen fibers in the dermis and are generally parallel to the orientation of underlying muscle fibers. So incisions made parallel to Langer's lines may heal better and produce less scarring than those that cut across. Now, what are the various procedures while giving incision? What are the various procedures they are followed? Sternotomy used for opening the entire thoracic cavity here. Then thoracotomy for surgeries on the lung, esophagus for applying a clamp to abdominal aorta. Then thoracoabdominal incision. So single large incision involving both thorax and abdomen, but this is not the preferred procedure. Thoracoabdominal procedure, that is not the preferred procedure. So then is in the abdomen, what kind of incisions can be given? That is vertical midline, most commonly preferred. Why? Because minimum blood loss, no risk of injuries to the nerves, ease of opening and closing the wound, wider exposure of the most of the abdominal and pelvic viscera. Phanon stele, that is transverse incision above the pubis, given for operation in pelvic region, has good cosmetic advantage. Then subcostal or Cocker's incision. Rectus muscle is divided, used for surgeries on gallbladder on right side and on spleen on left side. Coming to the paramedian incisions, facilitates better exposure to structure that are placed laterally. Chances of incision early are less. Why? Because abdomen is closed with multiple layers of fascia. Then it has cosmetic advantage because scar is minimum. Then McBurney's incision is given for surgery on the appendix. So this is the McBurney's incision. So this is all about skin, dermatomes and the incisions. Thank you very much.